Welcome everybody to Joe Merola and my lecture on psoriatic arthritis for the dermatologist. This lecture arose from a collaboration between master classes in dermatology and the Psoriasis and Psoriatic Arthritis Hub. Next slide, please. Both Dr. Merola and myself are boarded in both dermatology and rheumatology. I am in academics and I have a faculty position at Mount Sinai in New York City. Dr. Joseph Merola is currently at Harvard. He is also a dermatologist and rheumatologist, but he's the incoming chair at the University of Texas Southwestern Medical Center. Next slide, please. I feel very passionate about this, and so I'm going to get excited when I present it. I think the dermatologist plays a key role in prevention of disability due to psoriatic arthritis. And I will say upfront that I could not disagree more with the EULAR guidelines in this regard. And here's the reason why. Psoriatic arthritis is, in general, not that hard to diagnose, and it's common. It's the most common comorbidity of psoriasis. And so what if we make a mistake and we send a fibromyalgia or we send an osteoarthritis patient to the rheumatologist? They need a rheumatologist too. But if we miss the diagnosis of psoriatic arthritis, we can cause damage. Why is that? Because psoriatic arthritis is potentially disabling. And in addition, if one doesn't diagnose it early, it can even be more disabling. And there are data that show a delay in diagnosis of psoriatic arthritis of 6 months or more leads to more damage, including erosions, arthritis mutilans, disability, and poor functioning. So it's a shame that psoriatic arthritis is frequently undiagnosed. And in a paper that has been published, up to 41% of psoriatic arthritis presenting to rheumatologists were missed by their dermatologists. And we do have a warning sign of who's at risk for psoriatic arthritis. It's a patient with psoriasis. In 84% of patients, the dermatology symptoms or psoriasis precedes psoriatic arthritis by 10 to 12 years. So it is the dermatologist who can be the first to detect arthritis. And why does it matter? Because as of this presentation, there are multiple TNF blockers and IL-17 blockers, and there's one JAK inhibitor, upadacitinib, that not only control signs and symptoms and improve quality of life, but actually inhibit radiographic progression. So dermatologists can prevent disability by initiating treatment early on. And frankly, I don't know how a dermatologist can treat psoriasis if they don't know if they have psoriatic arthritis. About 30% of patients with mild psoriasis have psoriatic arthritis. And indeed, in clinical trials of psoriatic arthritis, your average PASI score is somewhere between 6 and 8, indicating that many patients with psoriatic arthritis have only mild skin disease. So that one has to ask every psoriasis patient at every visit, what about their joint complaints? Because we can pick up psoriatic arthritis early, and then whether we feel comfortable treating it ourselves or referring to rheumatologists, get that psoriatic arthritis taken care of. And with that, I turn the podium over to my wonderful esteemed colleague, Dr. Joseph Merola.
Thanks so much, Allison. We're going to go a little bit back and forth on this one, and then I'm going to make some comments about the GRAPPA guidelines and sort of collaborative approaches after this. But before I go through this, I think it's worth just saying that EULAR recently updated and presented their recommendations. And for those who have been following, I think it's easy to say that they largely mirror the GRAPPA guidelines, which I'll show on the next slide briefly. But there's one point Alice made at the beginning that I'll give her a chance to say again here, which is a little bit of the gaps in the EULAR recommendations. I think, they largely take a roughly domain-based approach, thinking about the different potential components of disease that may be involved. They look at the current evidence for each of the both CSD MARDs, TSD MARDs, biologics, and other therapeutics in an evidence-based way that face each of those domains. And so to Alice's point a moment ago, it's pretty hard for dermatologists to think about how to treat a psoriatic patient without first considering whether they have psoriatic arthritis. And one more level of nuance, what flavor of psoriatic arthritis do they have? And we'll come back to that. But Alice, I want to give you one more chance to drive home the point, particularly for our European colleagues, about where the EULAR guidelines may fall a bit short in emphasizing the dermatologist's role. And then I'll move on.
So it is my understanding that the EULAR guidelines say the role of the dermatologist is really only when the skin disease is not well controlled by the rheumatologist. And that puts the dermatologist at the end of the diagnosis of psoriatic arthritis cascade. In fact, it actually eliminates the dermatologist as having any role in diagnosis of psoriatic arthritis. And I believe that one is missing the ability to detect early psoriatic arthritis, which frankly, in dermatology practices is most likely to present as enthesitis and not frank arthritis. And I think this is a lost opportunity.
Right. And, I think there's been so much work, there has been so much work done and opportunities for easy access to, validated screening tools and other easy ways for the dermatologist to assess and screen for psoriatic arthritis. That's really low burden on the dermatologist, low burden on the office, low burden on the patient, including instruments like the PEST screening questionnaire. And I'll just put in a plug because we're very short on time for this particular presentation, but both for IDIOM, which is the International Dermatology Outcome Measures Group, which has really looked at ways to inform the dermatologist on screening, as well as disease symptom measurement, and algorithmic approaches to screening and treatment. So please have a look at our website, dermoutcomes.org, if you're interested in that. And with that, let me move forward, because I mentioned a moment ago that one approach to disease treatment is really this domain-based approach. And in the GRAPPA updated guidelines, you'll see not only the 6 sort of classical domains here: peripheral arthritis, axial, enthesitis, dactylitis, skin psoriasis, and nail disease, but now has been incorporated 2 key comorbidities, being IBD and uveitis considerations. The one I want to highlight here is, again, so these largely mirror the EULAR guidelines. I think these guidelines are very helpful. The only thing I think for the dermatologist to be aware of, and where I would argue they fall a bit short, is in the skin domain here. For rheumatologists, we're using this, for example. I'm not sure in the current era where we have head-to-head data about, comparative efficacy, safety, tolerability, et cetera, that this is necessarily the algorithm most dermatologists would use, nor does it, take a look at severity of disease by areas of involvement, nor by severity, underlying severity of disease, considering is it mild, is it moderate or severe, depending on impact on quality of life, for example. So I think they're helpful. I think there are still some shortcomings of the guidelines. But again, in the interest of time, I wanted to focus on this. And then we'll close a bit with some of the opportunities where we believe we can start to bridge the gap between dermatologists and rheumatologists, including educationally. So this is a slide I put together a while back. Just reminds us that we each have our role, right? So yes, psoriatic disease can appear occasionally complex now that we know there's skin involvement, there's joint involvement, but there's also a number of other comorbidities, cardiovascular comorbidities, psychiatric comorbidities, among others. Now, if we think about our role as the dermatologist, minimally, and this was really coming back to Alice's first slide, the ask, we need to make sure, yes, we're asking patients about how the psoriasis is impacting their quality of life and treating them to target. But we also are minimally charged with screening for comorbidities, especially psoriatic arthritis, and then either treating, diagnosing, treating, or referring to the rheumatologist, and then thinking about appropriate patient education and such. So, one of the key elements here is helping the patient build their team. So minimally, we're going to do the skin treatment, screening and referring for comorbidities. Similarly, for the rheumatologist, they have to treat the psoriatic arthritis, but they also have to understand that the skin matters. They have to treat to target, or if they're not willing or able or comfortable to again, collaborate with the dermatologist to get the patient to where their quality of life is optimized. So helping to build that team is part of the story. So how do we think about that? In a moment, we'll talk about interdisciplinary education, which I think is one way to bridge the gap. The other way is just collaborative care models. And in some places, there are very formalized collaborative care models where we literally have a derm in a room seeing the patient in the same place at the same time. And yes, that's wonderful and the patients love it, but it's not practical in most places. So where that is possible, we have some organizations like Pacman, ppacman.org, that support those combined clinic models. If you have those or you're interested in them, please take a look. It's certainly a really wonderful model for patients to get the best care and for education and collaboration and for research. But in the 90% of the world where we're doing basic, focused care, the way to probably best get this done is this key ingredient, which is facilitated communication, making sure that you have access to and know who the people are in your community who really treat psoriatic disease appropriately, who like to see these patients, who are comfortable with, a rheumatologist who's comfortable with and knows how to treat psoriatic arthritis appropriately, the dermatologist who's comfortable treating the psoriasis patient to target, who uses the full breadth of treatment options in the arsenal presently for psoriasis treatment, who screens for psoriatic arthritis, et cetera. And then facilitate communication can look like anything like knowing who to call or who to refer to. We've seen in some places around the country or in the world, it's physicians holding a spot on their schedule, that reverts if it hasn't been filled in a week or two for a psoriatic patient. It's having a phone number to call or text if you have a question. It could be communicating via an electronic medical record, and a number of other arrangements, a virtual grand rounds. That's interdisciplinary. So there's lots of ways to do this, but remember, help the patient build a team around their psoriatic disease. And really, we both obviously feel strongly about this, and I'll let Alice at the very end give us a summary. To that end, we mentioned that there are some, we believe, really educational gaps, both for the dermatologist and the rheumatologist. In this case, we believe that dermatologists really can benefit from seeing and learning at the interface of all of the other specialties that touch dermatology: rheumatology, infectious disease, plastic surgery in the case of of surgical disease. And certainly, for example, Alice and I have a really interesting program that we do at this Master Classes in Dermatology event that happens annually, where we will show you, for example, how to do the joint exam, how to do screening, how to think about psoriatic arthritis, through the lens of what's a rheumatologist thinking, what can I do as a dermatologist? But we do this across the breadth of multiple other specialties. And we hope you'll join us. The upcoming meeting is February 16th to 19th in a beautiful location. It's at the fringe of the El Yunque rainforest in Puerto Rico and San Juan. And it's just really one of the highlights of our year for sure. It's just an incredible meeting. And I'll show you another opportunity. But Alice, any comments about the meeting before this meeting? And then I'll show the other opportunity for APP and others.
I think this meeting, in contrast to the standard derm meetings, is one when it's teaching of community dermatologists by multidisciplinary teachers. And in addition, the atmosphere is much more intimate, so that attendees get to talk to key opinion leaders across multiple specialties and bring their problem cases. They get to interact with people who are actually moving their respective fields really forward in an intimate way that just doesn't exist when you have 1,000 attendees on an every 10 to 20 minute schedule next kind of meeting. And you're not hearing the same old lectures that you hear at every meeting from the same people. So this is, I think, a unique meeting. And I think its intimacy is one of the pluses.
That's wonderful. And we've been happy to partner with Psoriasis Hub on bringing you some of the content from this meeting as well. And the other opportunity is not just for our physician colleagues, but we know that so much of the care of our, in particular, psoriatic disease patients, but other inflammatory dermatoses patients that are relevant to both the dermatologist and the rheumatologist, and that's key, really happens in multiple different areas. And in this case, certainly for the advanced practice providers, our PA and NP colleagues, both in dermatology and rheumatology, as well as we know that there's educational gaps in a variety of other categories. Everyone from the MSL and other groups that are coming in to to chat with us. There's so many folks that really need to be educated on this very complex area, and I think we do a nice job of breaking that down both for derm and rheum. And so this is another update, which is master classes in psoriatic disease for APP crowd, and we cover, by the way, also hidradenitis, atopic dermatitis, and other updates, both for dermatologists and for rheumatology learners in a really beautiful environment. This is coming up very soon in November, 3rd to 5th in Las Colinas, Dallas. So very convenient. We'd be delighted to have folks join us for this again, and hope to partner with Psoriasis Hub. Any thoughts, Alice, on this one? And then we'll do our summary wrap up.
Again, besides the multidisciplinary aspect, which is unique, it's also the case that at the end, attendees do take a test, which is very reasonable test that if one hasn't been swimming in the pool, one will definitely do well anyway. But at the end, you get a certificate with it. It really has Joseph Merola's name on it, and you can prove that you're an expert, which I extremely helpful, whether you're in a practice where you definitely want to show that you know what you're doing, if only as a medical legal protection, but also you want to show it to be proud of it. But also, I think it would be important to have medical science liaisons know what they're doing, so that their company knows that when they visit a doctor's office, they're providing meaningful education. And I think that's unique. They're unique.
So with that, I think our sort of summary comments, if I may, is that I think you've heard from both of us that psoriasis really is, and the dermatologist seeing the psoriasis patient, is really at the key position to be screening for psoriatic arthritis, for getting patients to the right, either by referral provider, or that the dermatologist can own diagnosis and treatment of psoriatic arthritis, and that we have so many opportunities here educationally to really bridge our gaps in knowledge for the dermatologist, including the masterclasses meeting, where we'll go in much greater depth with regard to domains of disease, how to think about treatment, how to think about screening, how to do joint exams, all of those things, comorbidities of disease, both in the psoriatic disease realm, but also across the full breadth of other dermatologic conditions, everything from updates in skin cancer to inflammatory dermatoses, itch, surgical updates and management, et cetera. So Alice, I'll let you close us out.
I welcome collaboration and interest in the various organizations that we've been talking about. If you're interested in moving the field forward and thinking a little outside the box, we welcome participation in master classes, in IDIOM, in PPACMEN, GRAPPA. I think that my take-home message for the particular psoriasis field is be a hero, make a difference. Dermatologists ask about psoriatic arthritis, use freely available questionnaires where you don't have to do any work. The diagnosis and the target to treat to can be done just by the patient, and you'll be a hero, because at the end of the day, isn't it satisfying to have a patient give you a hug and tell you how you've changed their life? And indeed we do.
Wonderful. Well, thank you so much.